Good evening, everybody. Thanks for joining us for IU Simon Cancer Center's presentation, Keeping Our Eye on the Ball, IU's Leadership in Testis Cancer and Research Care. My name is Steven Crocker. I'm a newscast director at Wavy TV 10 in Hampton Roads, Virginia. I'm also a testicular cancer survivor. I was treated with an orchiectomy. I had 4 cycles of etoposide and cisplatin, and I had a retroperitoneal lymph node dissection done by our speaker tonight. The speaker tonight is a urologic oncologist at IU School of Medicine and IU Simon Comprehensive Cancer Center. He's an associate professor of medicine at IU School of Medicine and a researcher at IU Simon Comprehensive Cancer Center. His clinical practice and research interests are centered on urologic oncology with focus on cancer. And he's one of the few people in the world who's had his hands inside me. So this is Dr. Clint Cary, everybody.
Well, thanks, Stephen, for that introduction, and thanks for being a part of this. I think you being a part of this kind of helps bring the story together of why we do what we do and why all of us, the medical oncologist and the urologist here, are passionate about taking care of patients just like you. And so you being here and sharing some of your details is vastly important to us, and I think will be valuable tonight.
Well, I'm thankful to be here. I'm thankful to have been asked, and I owe you part of my life, so I'm happy to do anything for you. So I understand that you have a presentation for us tonight.
I do. So I'm just going to give a little background on Indiana University's role in testis cancer and highlight some of the advances from the surgical side of things, which might not be as well known as the medical oncology achievements. And so I wanted to talk a little bit about that. So give me a second here to just share my screen. All right, so so the title of tonight was actually was a lot more work than one would assume. We went back and forth on a lot of these and had a lot of good people helping me out with something that was a little bit more catchy than maybe my initial title. So I appreciate the help with that. But
great title.
Keeping Our Eyes on the Ball, and IU's Leadership in Testis Cancer Research and Care. So, you know, Indiana, we're in the middle of the country. A lot of people would think about Indiana as a flyover state going from coast to coast. And so, you know, the initial question I put up here is kind of how in the world did Indiana become a world leader in the management of testicular cancer? And it really was these two guys here who started this. This was John Donahue, who was the previous chairman of our department. And a lot of people obviously know Larry Einhorn, who is a medical oncologist who came up with a regimen that really changed the cure rates for metastatic testicular cancer. So it was kind of a perfect storm with these two guys being here at the same time and working in collaboration, and really set the construct for how multidisciplinary care should be delivered to work towards a cure for a particular cancer. So this all started with these gentlemen and really put this place on the map for a fairly rare disease. And so without them, they kind of were the catalyst of what we're doing today. A lot of this started with the use of cisplatin, and the first human trial started in the early 70s with this drug, and putting it in combination with other drugs was what Dr. Einhorn recognized and revolutionized the treatment for patients. And this story is well known, and I know Dr. Einhorn has talked a lot about this here at the Simon Cancer Center, nationally, internationally, and is one of the most well-known stories. So you have to take yourself back to these 1960s and 70s, and John Donahue actually came to Indiana University first in the mid-60s and brought some surgical skills with him that he had learned while training, and began operating on patients with metastatic testicular cancer at a time when there wasn't really any curative chemotherapy available. And so during this time, he was doing these really complicated surgeries because of a lack of chemotherapy. But because of that, he began to improve our surgical understanding of how to treat patients with metastatic testicular cancer. At the same time, some of these chemotherapy regimens were being discovered and how to use them in combination. And obviously the landmark study was from Indiana University, which put together 3 drugs that are fairly similar to the regimen now as far as the number of drugs. There have been obviously some improvements and modifications, but this combination chemotherapy that Dr. Einhorn put together really changed the cure rate for metastatic testicular cancer from the low single digits into the 70% range, essentially in a matter of a few years, which is unheard of with metastatic cancer in general. At the same time, CT scans were becoming available, and that really helped with staging of the disease. Previously, a lot of this was based on physical exam or other rudimentary type of imaging modalities. And so being able to see inside the body from an anatomic standpoint was immensely helpful as far as how to stage patients to know what the extent of the spread of their disease was, and then when we should operate and or when we should give this chemotherapy. This was an exciting time. Imagine all this new technology, new surgical understanding, new imaging modalities that were coming out. And so this was really an exciting time in medicine, but particularly at Indiana University with care for patients with testicular cancer. So getting into some of these contributions from the surgical side that our department has done over the decades, I just wanted to highlight a few things. So the picture on the left is the picture of what we call the retroperitoneum. So over the years, we began to understand that testicular cancer, for the most part, was very predictable once it got outside of the testicle where it was going to go. And so some of these early studies were led by Dr. John Donahue, and he mapped where the cancer was going during these operations. If you had a cancer in your right testicle, where was that most likely to spread? If you had a cancer in your left testicle, where was that most likely to spread? He also helped pioneer the nerve sparing technique, and we'll talk a little bit about that. The nerves that control ejaculation and therefore a man's fertility are also back in this area called the retroperitoneum, where you have to do surgery. And so being able to identify those and save those can preserve fertility, which obviously in a disease that happens in patients that are 20 to 40 years old, that's very important because a lot of patients haven't had their family yet if they so desired. He changed surgical approaches from being a huge incision, which went into the chest and abdomen, into just a single midline incision. He detailed how to do surgery after chemotherapy. Obviously, he had a lot of these patients here, given that Dr. Einhorn was treating these patients. And so understanding how to do that operation in a more difficult setting was a big contribution. Management of late relapse and understanding that that's been largely a surgical disease when chemotherapy no longer is effective. We've described how to operate on patients with very large volume teratoma after chemotherapy, which can be very challenging surgically. We've detailed and even came up with the term desperation surgery. I think that was developed by Dr. Donahue in combination with Dr. Foster to describe patients that have failed basically all the lines of chemotherapy, and their tumor markers are still rising and their disease is progressing, and doing surgery in that setting was defined as a desperation surgery, and understanding that we could still cure patients despite failing all these chemotherapy regimens. So one of the things that's decreased the morbidity of this operation, so this anterior approach that I just described, went from this incision that went into your chest and came down into your abdomen in the picture on the left to just a simple midline incision to the picture on the right. Obviously, you can understand that from a healing standpoint and from a postoperative pain standpoint, that was a big advance of being able to still do this operation through this approach. Like I talked about, mapping where the cancer is going. So these are some of the early actual color photographs that were made by Dr. Donahue in this publication in the early 80s, where he operated on patients and took very detailed notes about where this cancer was going to spread and gave percentages of the likelihood of finding it in these locations. And this really led to the development of surgical templates, knowing where we should operate and knowing where we don't have to operate, which saves men the ability for fertility by saving nerves. And this is just a diagram that our medical illustration department has put together to detail these templates, and they're just shaded by different colors based on if the tumor was in the right testicle or left testicle. And then there's still patients who need a full bilateral dissection with more bulky disease or certain scenarios. This nerve sparing approach was, again, pioneered by Dr. Donahue. And there were some other investigators at other institutions who were also working on this concept as well. But certainly Dr. Donahue is at the forefront of this. The understanding of this anatomy, as you can see on the diagrams on the top, there's these nerve chains that come down the spinal column and give off the nerve fibers. And then the photograph here at the bottom shows how they are intimately associated with the aorta, the main blood vessel, that artery in our abdomen, and the inferior vena cava, which is the main vein bringing blood back from our lower extremities. These nerves are very intimately associated with these blood vessels. And so knowing where they are and how to save them was also a huge advance for fertility aspects for men. So all of that was started in the 60s, 70s, and 80s continues today. These are just some examples of how our department, medical oncology department, continues to lead the field with our work to continue to strive to be better. The study on the top was discussing how much we have improved the ejaculatory status and fertility rates. The study in the bottom left was about how to continue to improve morbidity associated with the surgery, so patients don't have to stay in the hospital as long and can recover quicker. And then the one on the right deals with one of the chemotherapy medicines, which we'll probably talk about in the question section. But there's always been this big fear with this medication of pulmonary or lung problems. And this was a study showing that, at least here at Indiana University, that risk is very minimal when patients are treated appropriately. So this is something that, obviously everyone who deals with patients with testicular cancer here at our center is and should be very proud of. I mean, the work that comes out of here really drives this field forward. There's certainly other centers across the world who also do excellent jobs. But I think based on our history of how we've managed these patients over the decades, I think a lot of people look to us for our ideas and what we're studying in this patient population and how we're trying to continue to advance care for these patients. And these are just some selected publications over the years. So what benefit do patients get by coming to Indiana? I think I've summarized this well for everyone. And this really boils down to just decades of pioneering experience. And, not to sound like a marketing commercial, but, that is a true statement. That isn't just something that is thrown out there lightly. This is something that has been a passion of this center for quite some time. This was an interesting figure that we've shown on many occasions. This is where do our patients come from? And they really come from all over the country. And this is just patients that are mapped by their location in the United States. And this does not encompass worldwide, where we do operate on patients from almost every continent out there. And just to give you some ideas, so patients come from all these locations. Clearly, there's a big population that comes from the whole eastern side of the U.S., but even patients coming from the Pacific Northwest, and the different colors are associated with how many patients have came from these locations. And this represents probably 10,000 patients that have come here for this operation. And that represents one of the largest databases, if not the largest database in the world, that we use to study basically how we can continue to get better. And what does all this mean? And these were some publications. One was published by one of our medical oncologists here as the first author. And when we compared the survival of patients treated at Indiana University compared to national databases, SEER database is a national database. And the benefit of all this experience here at Indiana University is that survival from this disease is better at Indiana compared to national averages. And then this was a paper that actually was published by a different institution, but it was basically comparing surgical mortality within the first 3 months of surgery from these complicated retroperitoneal lymph node dissections that we do to national averages. And as you can see on the right, the mortality in both low stage disease and metastatic testicular cancer is quite a bit lower here at Indiana University. There's essentially no mortality for low stage disease. And for the most complicated patients, we're under 1%, where the national average is 6%. So this experience is something that continues to benefit patients. It benefited them in the 70s, and it continues to benefit them today, and we only continue to strive to get better at this. So that's my spiel there. I'm happy to answer any questions about that, but I think we do have some questions to get to here as well. So thank you for your attention, and I'm looking forward to the rest of the time we have.
Yeah, thank you so much for that presentation. And I have to say, your confidence with the nerve sparing is part of the reason I came to Indiana University. When I first was diagnosed, the first thought that I had was not being able to have kids. So knowing that you were able to do that was a huge decision maker to go to Indiana. So we do have some questions that span from newly diagnosed to long-term, and then the RPL&D. We'll start with the newly diagnosed question. What advice would you give someone newly diagnosed with metastatic testicular cancer? What is routine follow-up after treatment is deemed complete?
Someone with newly diagnosed cancer, I think I guess let me step back. So just to put this in context, this is a fairly rare disease. It's the most common solid tumor for men, from the early teenage years up to 40 years old or so. It is the most common solid tumor, but relatively speaking, it's actually not very common. There's only between 9,000 and 10,000 men per year that get diagnosed in the entire country. So when you put that in comparison to prostate cancer, breast cancer, colon cancer, those numbers are pretty pale in comparison. So seeing someone who has experience with patients who've developed metastases is not as easy as one would think. And so I think the biggest thing is if possible, seeing a medical oncologist that understands the disease, understands the chemotherapy treatments, and try to get the best understanding of the extent of your disease. There's different classifications that you could fall into, and that matters because of the different types of chemotherapy regimens you may need. And so really trying to see someone in this disease with experience and trying to get the best care that you can would be the first piece of advice. And then there were some, I think, tail end part of that question that I remind me what those were.
Yeah, it was what is the routine follow-up after treatment is deemed complete?
Yeah, so um, there's some nuance there, but I think in general, um, that's going to require continued CT scans, chest X-rays, blood work that includes serum tumor markers, which are AFP and beta HCG. That's going to be done for the next 5 years after your treatment. The frequency of those can be a little bit varied depending on some things, but it's most intense in the first 2 years, and then that tails off over years 3, 4, and 5 somewhat. And then certainly if you've been treated with chemotherapy, at least here at Indiana University, I know our medical oncologists tend to follow patients lifelong. You don't need imaging studies lifelong. They usually drop those off after the first 5 years, but they do continue to check serum tumor markers annually. And that's to monitor patients for the very small risk of having a late relapse, which is defined as having a recurrence more than 2 years after your successful treatment. But also to monitor for some potential long-term side effects of chemotherapy, which I'm sure we'll have some questions on too.
The next question, as you alluded to, is can you discuss long-term side effects for chemo drug, bleomycin, et cetera?
Yeah, so you cut out a little bit there, but I think you're basically wanting to know the long-term side effects of the chemotherapy regimens and bleomycin being one of those. So at Indiana University, the 3 most common drugs we use together are bleomycin, cisplatin, and etoposide. We have a lot of research that's being done and led out of here by Lois Travis, who's a researcher who has a substantial amount of grant funding to understand the long-term side effects of these chemotherapy medications. What she's learned over the years, not only her, but other researchers, is there certainly are some potential effects of chemotherapy. Secondary cancers are a big one. So you can have an increased risk of bladder cancer, colon cancer, lung cancer, and others. And this risk seems to increase certainly after 10 years of treatment and remain elevated for several decades. Etoposide drug and cisplatin also can induce some leukemias. And so monitoring for these throughout the rest of your life is something that is very important. We've learned that some cardiovascular disease is increased in men who've been treated with chemotherapy with these drugs. Some of this is due to metabolic syndrome, which seems to occur at a higher frequency. Things like high blood pressure, obesity, high cholesterol levels. Something called Raynaud's phenomenon, which is where you have this sensation in your hands and feet, and especially in the cold weather, which can be ascribed to the bleomycin, but can also be due to cisplatin as well. There's fertility concerns long-term with chemotherapy. Cisplatin is probably the most important drug for causing this. This is usually dose dependent, and you can recover that ability after the chemotherapy is over. Some men can develop low testosterone levels and need testosterone replacement due to chemotherapy. There's some both near-term and short-term complications, such as damage to the nerves, where you have pain in your hands and feet, damage to hearing, and some kidneys and lung toxicity. One of the biggest things with bleomycin is it in the near term can cause this inflammation of the lungs, very rarely something called pulmonary fibrosis. And I think that's what scares a lot of people from medical oncologists away from this drug. But it rarely happens. But it can make some medical oncologists nervous. So I think that's the big components of some of this. And I think I would just kind of stop there.
Is there anything anybody can use on to mitigate any damage to their lungs?
Is there anything that people can do to reduce the damage to their lungs?
Yeah.
Hang on one second. This is so I'm going to take one quick minute because my son is here. So hang on one second. Okay, sorry about that. There's nothing really, I mean, I don't think that a patient can do per se. You know, the issues that, I mean, that is one of the side effects of these drugs. I don't think there's much that patients can be proactive about. Certainly, you know, not smoking or stopping smoking is very helpful. How we manage those patients during surgery, if they have received those drugs, is very important. And so here our anesthesiologists are very in tune to fluid management, oxygen levels, and things like that. But I think that would probably be the biggest thing, I guess I would say from a patient perspective, is if you do smoke, stopping smoking would be a very wise decision.
Probably wise all around. Another question is testicular cancer hereditary?
That's a good question. I think the best data on this comes out of the Norwegian countries, just because they have these cancer registries that can really track patients over time. And they have shown that there is a higher risk if you've had a brother that's had testis cancer, or if you've had a father that's had testis cancer. There is a higher risk in you compared to the general population. And so that doesn't mean that we screen patients with ultrasounds or anything. That's just knowledge that family members should have, and self-exams are important in those situations.
My brother's a hypochondriac, so he's not going to like that answer. Okay, so how has the role of RPL&D in the treatment of early stage testicular cancer changed over the years, and do you see it evolving further in the future?
You know, I talked a little bit about that, about how it's changed, how Dr. Donahue pioneered some of those changes. I think the biggest thing is that the morbidity of the operation is drastically reduced compared to when he was doing those operations in the 60s, 70s, and 80s. Because of his work, our understanding of the anatomy has improved so much that the surgeries have become much more efficient. These used to be all-day operations, and now they're done, depending on the complexity of these operations, they can be done in only a few hours, if that sometimes. And so the time that patients need in the operating room has been reduced. Their need to be in the hospital for as long has drastically reduced. So I think our surgical understanding that it's been passed down from generation to generation here at Indiana has drastically reduced the morbidity. I showed that one study that we published about different medications that we've recently discovered that can keep patients more comfortable and be able to leave the hospital sooner. I think those are the biggest advances. I'm not sure that there is another huge advance on the horizon, but we'll see.
Will there ever be a time when it is not necessary to travel to a center of excellence for a RPL&D?
Yeah, that is a great question. And I wish the answer was there will be a time. But I think that centers of excellence for this particular disease will always be needed. I think there's only going to be a small number of places in the country that can do this to the highest level. The reason I say that is, from what I talked about earlier, there's not many men that get diagnosed with testis cancer. And fortunately, the vast majority don't need this kind of operation. But unfortunately, because of that, there's not a lot of urologists or surgeons that are able to get a big experience. And so I think because of all those factors, that centers of excellence are going to be vastly important for the foreseeable future.
What is the status of standardization of RPL&D surgery across the field?
Yeah, so this was one of the pre-submitted questions that I saw, and I'm not sure exactly what was the intent of this question. I'm not sure if the person was wanting to know about standardized templates, about how we decide how to do that, or maybe standardization where it could be done in multiple locations. So I wish I had a better answer. It'd be nice to have a follow-up about that question.
No worries. Are there any prognostic factors for a patient's retroperitoneal node response to primary chemotherapy? For example, is it reasonable to assume pre-chemo half of patients? Does histology play a role in the response? Basically, before starting chemotherapy, is there any way to estimate who will ultimately need a post-chemo RPL&D?
Yeah, so I think some of this is experience. Seeing CT scans before chemotherapy and have an understanding. So some of it is just experience of seeing these patients. There are some things that I think give us some clues. Certainly men who show up with very large disease inside the abdomen, we know that the likelihood of them normalizing their CT scans after chemotherapy is going to be quite low. And so those are patients we think will likely need a post-chemotherapy surgery or post-chemotherapy retroperitoneal lymph node dissection. There are some histologies that do and don't respond to chemotherapy well. Things like embryonal carcinoma, seminoma respond very well to chemotherapy and will normalize many CT scans. If we have an inkling or an understanding that there may be teratoma that's spread outside the testicle, we know that teratoma cannot be treated with chemotherapy. Sometimes there's more than one of these histologies that has spread outside the testicle. It may be teratoma with embryonal carcinoma or choriocarcinoma. And so those latter two would respond well to chemotherapy. The teratoma would be left behind that we would have to do surgery for. So it's a bit of histology, the size of the mass, but there's no 100% prediction of will you need surgery or not until you get those follow-up CT scans.
Yeah, I was one of those cases where mine ended up being scar tissue, I believe, but like you said, there was no way to know. Right. Patients with clinical stage 1B with predominantly embryonal carcinoma and lymphovascular invasion have up to a 50% chance of relapse. Why are the different treatment options controversial and left to the patient to decide?
Yeah, so with patients with that stage, it is a bit of a coin toss. If they choose surveillance, there's about a 50% chance roughly that they'll have a relapse. The good news is that in those patients, they, for the most part, will be cured at the time that they relapse with whatever, either surgery or chemotherapy, or maybe both. The treatments, there's three main treatments for that stage. The reason that patients really get to decide for the most part is that the survival outcomes with all three of those approaches are exactly the same. They're right around 99%. And that's probably a good thing and a bad thing. Some people just, want to say, okay, this is what I have, tell me what to do. Other people, want to have options. And so it's a good and bad thing, I think. Some people, it is argued at some of our conferences, which one is best, surveillance or one cycle of chemotherapy or surgery. And they all have trade-offs. Everything has some potential downside to it. And so, who are, there's multiple ways to look at it, but who are we to tell you this one's better? Our job is to present you with the options and let you decide, well, based on my life, this one may be better. Until there is, well, for these particular ones, there won't be something that says you're going to survive better. And so just because survival is excellent with all three of them. And so, so it's a complicated issue. We actually, I was interested in this question, so I had actually put together a research group that was going to basically get men in a room, about 10 survivors in a room that had clinical stage 1 disease, and ask them, how'd you choose what you chose? And we actually had it all set up, and there were so many guys who were coming in from all around surrounding states that it didn't work out. It was too complicated. And so we never got it done, but it's an interesting question.
I was stage 2B. I would just tell you that the reason I did the RPL&D was because I wanted to put it all behind me. So you got one answer. What are the best methods to prevent recurrence, and what are the best body detox methods to prevent recurrence?
Yeah, I think from a patient perspective, I mean, the easy answer would be live your best life. Try to be as healthy as you can, and exercise, eat. Don't eat fast food all the time. But I don't know if there's a lot of research that says if you do this, you won't have a recurrence, or there's not any research that says that. Also, as far as the detoxification question, again, there's not a lot of research showing that, if you change this around the time of your diagnosis, you will decrease relapses. I think, if you look at that field of research, basically lifestyle changes and in a lot of cancers, another field of urology is prostate cancer. And there's a lot of work looking at diet to slow down prostate cancer progression. And that's largely centered around what makes sense. It's basically a heart healthy diet. You're getting exercise, you're limiting your amount of red meat intake, you're eating more of a plant-based type of diet. When you are eating meat, it's more fish-based types of protein. And so that makes sense. And that's been shown in prostate cancer. But for testis cancer in particular, there's not a large body of research in this area.
Interesting. How can you determine a patient's need for hormone replacement therapy if a baseline was not taken prior to the orchiectomy?
Yeah, so it's always nice to have a testosterone before one testicle is removed, just to see if there's any changes post-operatively. But largely it's symptom driven. It's actually debatable in the urologic world about what is a normal testosterone. And that's because some men function at a testosterone that may be low for some men, and other men are fine with that level. And so it's largely symptom driven. So, after your orchiectomy or after your chemotherapy or after your RPL&D, if you're having trouble sleeping, irritable, significantly fatigued, no matter how much sleep you get, those are signs of low testosterone, and you should be checked. And if it's low, then you need replacement. So it's nice to have that level ahead of time, but you don't have to have it.
We got about 5 more minutes, so we have one more question. Does an atrophied testicle caused by having the mumps create greater risk of developing testicular cancer?
The short answer is no. Having a smaller testicle could mean several things. One reason we'll see smaller testicles is if patients were born with a testicle that wasn't descended down into the scrotum. That is a risk factor for testicular cancer. The mumps itself, there's actually somewhat of an increase in mumps, and I think that's because of the vaccine issues at large that people have issues with, or want to avoid those vaccines for some of those childhood diseases. but there have been actually studies to see if mumps is related, and there hasn't really been a consistent trend with uh, mumps or chitis or getting an infection like that increases one's risk of testis cancer.
So I just want to say that early detection is key to all this. Mine metastasized, I believe, because I waited too long. So kind of like, with crime, if you see something, say something with your body. So no shame. Dr. Cary, thank you so much for being a part of this discussion, and you're a hero to so many.
Well, thank you, Steven. And again, thanks for being a part of this. I know it may step outside your comfort level, and mine too, actually being on the big screen. But I think this is important, and I think you're doing the right thing by being an advocate. I know you're involved with some foundation work as well, and trying to spread the message about just being aware of testis cancer. I think some people maybe put off going to the doctor and things. So your work is important. And so I appreciate you just as much.
I appreciate you mentioning the foundation. I'm a board member of the Testicular Cancer Awareness Foundation. And in those circles, a lot of people point to Dr. Cary and Dr. Einhorn. So you guys are doing good work.
Well, thank you.
Thanks everybody for watching.
Yeah, I appreciate everybody tuning in tonight, and hopefully this was entertaining and educational. So everybody have a good night.